Sounded good.
What's up, everybody? I'm so excited to have you here today. Y'all know I have to love you if you're going to speak on this webinar series because there's a very thorough vetting process and a cool factor that you must meet, and also inspiration, and have something of value to share with us. And let me just tell y'all about Dr. Mitch Malley. This is a man who really doesn't need an introduction because, like, everybody knows him worldwide. But my introduction to Dr. Mitch Malley happened a long time ago, almost a decade ago. I had been going to the chiropractor, and I had an issue with my knee from running. I know that shocks y'all, but I was running every day. My knee was giving me so many problems, and no matter what we did, it just never got better. And my chiropractor suggested that we might want to look at an invasive surgery to fix it. And I'm not a big fan of needles, much less anesthesia or anything involving surgery. But Dr. Foxworth was like, before we go that route, we're going to an event in a month. Dr. Mitch Malley will be there, and I want him to look at your knee before we even walk down this road towards surgery. And so we get to the event. We are not even there 2 hours. We run into Mitch and his wife in the lobby, and the doc's like, "It's so good to see you." They talk real quick, and he goes, "Oh, and by the way, I'm going to need you to look at her knee and possibly adjust it because it's been recommended for surgery." Y'all, he has adjusted my knee right then and there, and I have never had a problem with it since, ever. And I'm not the only person who has testimonials like this about it. My husband met Dr. Malley 5 years ago. He was standing there waiting for me, accidentally got into a line of people who were being adjusted by Dr. Malley at an event and didn't even realize it till he was at the front of the line. And since he was there, he got adjusted. And all these years later, he still talks about it enough that my son walked in here, saw Dr. Malley's name and said, "Oh my gosh, that's the speed adjuster." That's how much we love him. But obviously, he's internationally known, especially for his extremity adjusting, which is top notch. And he is here today to share with us a little bit of that knowledge and all of the different things that really impact low back pain and how you as a doctor can help your patients feel better than ever and get better outcomes. So now that I've spent 3 minutes gushing about how much I love this man, Dr. Malley, it's all yours.
Thank you so much. I really appreciate that, Christy. Not often you get to hear your own eulogy, so thank you for the wonderful accolades. Welcome, everybody. And hey, with COVID and quarantine, and I'm sure we're all sick and tired of hearing all about that, but lemonade out of lemons. We have a lot of material to cover today, and we're going to begin right away by letting you know of, since most people are having a little change in their life and perhaps having to stay at home or less hours in the office, what a tremendous opportunity for you to have an educational program like ChiroHealthUSA puts out with webinars with fantastic information. So that spawned the interest of my legacy of 40 years of work in developing the online program called Extremity Experts Academy. Get ready. I'm going to give you some snippets, and we're going to talk about first what the mind can conceive and believe it can achieve. And Napoleon Hill has many other wonderful success things, but when you look out into the horizon, you know, it's funny in life, when you look through the front windshield, the rearview mirror is actually quite small. So this too shall soon be behind us. You know, your knowledge is power, right? I do talk very, very fast, and I want to give you as much information as I can. I want to overwhelm you. If you forget something, you can reach out to me at any time. So your knowledge is power only if you utilize it, right? Knowledge doesn't mean anything unless you empower it. So today we're going to talk about the 5 hidden secrets of recalcitrant low back pain, sciatica, and scoliosis. And what would those 5 be? I'll bet you might be pondering on what could those 5 possible secrets be. Well, we're going to go through those first of all, talking about how foot mechanics causes and or contributes to your low back pain. Epidemiologically, and I would like to tell you that we have about 324 million people in the U.S. population. About 20% of them are going to suffer approximately 1 to 1.5 problems with their feet per year. What a tremendous opportunity for growth of your practice, right? The pain and the agony of defeat. My jokes aren't that great, right? Anyway, when we consider the number of people who've had surgery for fallen arches, give me a break. bunionectomies, the body's producing that extra bump, if you would, as a sixth toe because the amount of overpronation and the collapse to your core center of gravity. So when you think of these number of conditions that contribute to low back, about 50% fallen arches, that equates to about, 100 and some million people, right? So when you stop to think about this, yes, feet have a tremendous opportunity for growth in your practice. Epidemiologically, feet in a 6.5-year review of nearly 19 sports, they found that approximately over 25 to 30% of injuries occurred in the sports to the foot and ankle. Once again, if you sprain an ankle, you overstretch ligaments. I work in a surgical center, and my surgeon buddies say, come on, Mitch, what on earth do you do for a sprain? For God's sake, didn't they teach anything in chiropractic college? Sure. Did they teach anything in med school? And they look insulted. I said, it's very simple. They go, what do you do? Adjust ligaments? I said, I jokingly said, let's go back to that fibroelastic connective tissue between two bones. How is it possible to overstretch partially or completely tear a connection between two bones unless one and or the other bones move beyond their normal physiological plane? Just like a dislocated shoulder. The word's medical and it's called subluxation. So quickly the surgeon's mask goes back up. The inversion sprain, look at this article in January of 2019. Dr. Craig Young, MD, you can look it up, said there are approximately 23,000 plus ankle sprains per day. That accounts to over 30% of injuries in sports, you guys, 50% of injuries to the knee. So when the foot is planted, you have pivotal maneuvers, and those we'll soon see how they affect the knee, the second contributing factor to low back problems. Now, one of my favorite articles in Journal of Sports Medicine by Fredrickson says 85% of low back pain is due to a loss of structural integrity between the spine and the lower extremities. If you know mathematics, if A equals B, then B equals A, right? So then the lower extremities could be contributing to the spine and low back pain, right? That's called the Valix phenomena. Ladies and gentlemen, my colleagues, the afferent is the return back up to the spine. So if you have a patient with spinal problems, how are you so sure that it's a spine or something distal contributing to it? Should have an aha moment because 3/4 of runners have external rotation of their tibia and approximately 2/3 to 3/4 of them overpronate. So faulty foot mechanics also will affect knee, hip, and pelvis, thereby causing scoliotic changes and low back pain. So here's one of our most valuable players in the NBA of Canada. Here he is, and somebody caught a perfect picture of him right when he sprained his ankle. Now, the next one I'm going to show you is an athlete, a pro NBA player, who I will leave nameless. I have to do so under HIPAA. But this next individual, you're going to see me set his cuboid after 5 years in a walking boot, has had every physical therapy, injection, and everything. Watch, turn up your volume a little bit, and observe as I set the cuboid. That right there, he did not put his walking boot on since. He's not had a problem, and that was in slow motion. He got up and was absolutely amazed. You can also watch that on my YouTube channel. That YouTube channel you'll see later is drmitchmalley.com, drmitchmalley, MALLY.com. Turn up your volume, click on videos, and watch and enjoy. This guy was walking with a boot for 5 years. He would take it off to play and put it right back on because he'd re-injure it. Hey, look, once a sprain, that's right, always a sprain. And the reason is the articular congruence is lost after the first misalignment. This article is from the Journal of Orthopedic Trauma by Steele. The effect of ankle stability being related to articular congruence. Why don't we replace ankle with the word any joint? Wouldn't that also be true? Any joint is stable if it's related to its congruity. So any misalignments like this one, ouch, we've all experienced this at some point. Also, Journal of Sports Medicine talking about overpronation reported to be one of the key factors in common running injuries. But look what else they talk about. Leg length discrepancy. Later, we're going to talk about that, as well as femoral anteversion, asymmetry of hip, and how that occurs as a result of faulty foot, then knee, hip, pelvis, low back. So hold on to your horses. We're going to go through this really, really quickly, and there will be time for questions in the end. We have to cover basically a lot of material. So when you look at the 3 foot types, the one on your right is obviously the normal foot. The one on the top left is called That's right, pes planus foot. And the one on the right is called, the bottom is called the cavus foot. But if you look right here, this is called the CIA, the calcaneal inclination angle. And if you look at this one right here, you'll see there is no angle, making that a planus foot. And the bottom one, you'll see that elevation that is going to create the contour typically noted as the cavus foot type. So now we're going to talk about what I've put together in 40 years as biomechanics of what occurs in the ankle and foot and what to look for bony landmarks on the x-rays when you start to shoot them. Immediately, the first thing that's going to happen is called ground reaction force, heel strike, right? No news to you. This is going to be all normal. Heel strike causes the spring ligament to stretch, the navicular to drop, the forefoot to go from the fifth metatarsal to the big toe for toe off, and the elongation of the plantar fascia, and then it relaxes. And right back the same thing. But now what happens when bones move beyond their normal juxtaposition, these same misalignments are going to occur as we're now going to note above. Let's look to the top illustration now. On x-rays, this is part of 40 years of work on all the extremities. My Rankinometric analyses can be found in my DVDs and all my courses that we offer, as well as what's called the Extremity Experts Academy. So get excited, ladies and gentlemen. Go ahead when you x-ray a foot and ankle. What are you looking for? Yes, of course, fracture, pathology, and spurs. That's the most common. However, what about the malalignments? Take a look at this arc on the talar dome and a matched arc to the calcaneus. Those should intersect without any deviation, as you'll soon see what we see on routine x-rays on the middle picture in just a moment. The medial longitudinal arch should be 12 to 18 millimeters. On an average, 15 to 18 is more correct. And the subtalar joint should fit perfectly with the calcaneus. Now, inflection and extension during gait, the plantar fascia will go from elongation to relaxation and elongation to relaxation. And that's the steppage gait process for toeing off in normal ambulation. Now focus your eyes and attention, if you would, to the middle illustration, something that you've not heard before. I have never, ever once seen or had an x-ray or anything where the talus was anterior to the calcaneus. Not once. Therefore, I can show you on every x-ray these landmarks, and I hope that you would do so as well, is look for these landmarks and show the patient, if these were two pieces of a puzzle, Mrs. Jones, does that look lined up? Does that one look lined up? No, they're like two different zip codes. Well, notice the talus is in fact posterior. And when I discuss this with orthopedic surgeons and podiatrists, they kind of laugh and they said, what do you mean the talus can move anterior? Where's the rest of the foot going to go? And I said, touche. Well, this is just something some people teach out there, and I just happen to dispute it based on physics and understanding the anatomy and physiology of foot function. Well, they agree 100% with me, and they know foot function. So let's go ahead and talk about the next thing of what happens when your foot inverts in a sprained ankle. So on inversion, it is actually a known fact that your tibia rotates externally. That's normal sequence of events. When the foot pronates, look up on foot levelers, for example, when the foot pronates, the tibia torques internally. But the acute injury of the inversion sprain causes the tibia to rotate externally. And what happens at the ground reaction force, remember, causes the heel to elevate posteriorly, anteriorly it'll plantar flex, and the medial longitudinal arch will collapse as the foot will now end up in an overpronation. So if somebody says their foot is an overpronator, then what do you know is happening at the hindfoot? Oversupination. That's why the heel wears down on the lateral margin of somebody's shoe, is because the hindfoot oversupinates, causing the forefoot to overpronate, which can lead to metatarsus varus and hallux valgus, or a bunion formation. This is all scoliosis of the foot. So let's talk back in Galileo's day. For example, Galileo said that basically a beam can span 200 feet before it has to be widened for its strength. Think about that, a beam, like a bridge. If you take an arch of a bridge, it's 4 to 5 times stronger than a beam, which means that if a patient has a collapse of a longitudinal arch, their foot's going to be wider, as we'll soon see in another illustration from research. The flat foot is wider and thicker, And that's what happens when you lose the arch. It will elongate. So in this case, an arch supporting the patient will be 4 to 5 times what? Stronger and more efficient in sports. Here's an example of one of those research articles. Foot Levelers put out an article years ago of 306 chiropractors and CAs they evaluated for pronation and found less than 1% were actually within the what we call a well-balanced foot. Now take a look at the foot type from the left side to the right. The wider the foot, the more pronated the foot, the wider it is. So a bridge is going to be a normal arch will be more narrow than a collapsed arch. What are some of the consequences of pronation? As I run through a list of these, subluxations, obviously, we all work on those. All the foot type and leg pain, shin splints, tendonitis, knee pain, chondromalacia patella and hip pain, ITBF, bunions, functional short leg. We're soon going to talk about the one that schools don't often think about, which is the anatomic or structural short leg. Remember, structure equals function. So if you have functional short leg, you probably have something structurally causing it. And we're going to talk about why you don't stretch plantar fascia, why you don't stretch piriformis, and stop digging through somebody's intestine to do a psoas release. While those might work for you, we're going to talk about options as to why those are occurring and how to, in fact, correct those, including the low back pain sufferer who tried everything. As we go through this now, let's go ahead and talk about what happens when you see an Olympic athlete come to you who's recalcitrant low back pain, sciatica, and these are the worst flat feet I have ever seen. You could call it fat feet or flat feet, but these are fallen arches. Now, this individual flew from Arizona to me, and this athlete suffered needlessly. But when I said that his low back problem was actually due to his feet, he says, "Doc, I'm in the swimming pool all day and night." I said, "How did you get to the pool? How did you get out of the pool? How did you dive in? When you dive in the pool, swim and do flip turns, you're losing performance time. You think it's a flipper that's giving you an advantage. It's a distinct disadvantage affecting your performance in a controversial way. So correcting the back problem means we have to correct the faulty foot mechanics. Listen, you need to find the root source of a problem. If you pull a weed at the top, it'll always grow back. Now, Jade, here's an individual that had suffered plantar fasciitis for 2.5 to 3 years. She has tried everything. She has had her feet taped. She's had them wrapped, strapped, orthotic. She's had them stretched, the Strasbourg boot, the Strasbourg sock. She's done all the soft tissue, physical therapy, chiropractic, myofascial release, and you name it, including acupuncture and shots. And then, to top it all, she underwent the topaz surgery, ladies and gentlemen. The topaz, I'm sure the audience may not know what that is. There's about 800 plus of you. The topaz surgery where they drill 38 holes were drilled into the bottom of her foot to cause a bleed that would cause maybe perhaps decrease in scar tissue and increase in vascularity to promote healing. Ludicrous. It failed. So did everything else until we corrected her calcaneus. In the very first treatment, restoring the alignment of her calcaneus that was posteriorly dorsiflexed and inverted, she immediately took off her shoes and she said, "My God, I feel an arch for the first time in my life." You can watch that on drmitchmalley.com, and you can watch a number of those just at the very top. Select videos, turn up your volume, and observe. Seriously, do people need to undergo these procedures? No. Become an Extremity Experts Academy attendee. Take my online courses and programs and learn the techniques, buy the DVDs that we have, and learn how to make an efficacious, cost-effective treatment plan that will build the practice of your dreams. Look, did you guys know the muscle testing? You could actually bill for muscle testing on a different day as a regular examination. So what is the value? The value is significant. In the EEA, the Extremity Experts Academy, we also talk about how much bigger and better your practice will be when you charge for the things that you don't normally charge. If for a low back pain, that all you do is x-ray the low back and examine the low back, what about how we just talked about how the feet are going to change the gait, your core center of gravity affecting the spine? So the feet and leg length and knee problems and femur, but they complain in the low back. Look, I explained to patients, gas light, gas tank. You cross your leg, your foot falls asleep. Do we treat your foot? Again, the patients learn through these analogies. So I'd like to right now talk about the CIA, not the government agency. We got sick and tired of hearing that. But plantar fasciitis and Achilles tendonitis. Look at the difference between the left MRI, that sagittal image, comparing it to the right. Look at the CIA. The CIA, once again, ladies and gentlemen, is right here. The calcaneal inclination angle that you're seeing right here is flattened. So let's go ahead then and see what happens when we look at that angle. There's a calcaneal inclination angle. Look at the difference. Now look and focus on the plantar fascia, followed by the Achilles tendon, and look at the thickening. Also, I want you to take a look, if you would please, at the right here, the talus, the subtalar joint, and the back end of the talus is in fact posterior to the calcaneus once again. You'll see that repeatedly. Start x-raying thousands and thousands and thousands like I have, and you will start to see my research of 40 years. Watch a short video clip. The first move is the calcaneus posterior dorsiflexion and medial rotation. Remember, when the calcaneus moves posteriorly dorsiflexed, anteriorly it will plantar flex. When the posterior aspect of the calcaneus moves medially, the calcaneal cuboid joint will become open with a lateral wedge. The doctor takes a wide stance. Let's move this to the adjustment. Hand is placed along the let's try that again. Here we go. Calcaneus, thumb in front of the malleolus. The two thumbs form a 90-degree angle. The arm and elbow are pointing toward the line of correction. And the procedure is performed with a rapid pull, superior to inferior, medial to lateral pull of the calcaneus, evert the calcaneus, and thrust. I will now perform the calcaneal correction at live speed. This is soft hands, move very quickly. Watch. So that is absolutely awesome, and those are the results we get. The calcaneus reduction is performed as follows. But remember that the calcaneus, little technical difficulty, is posteriorly dorsiflexed. So as we look right there, take a look at the calcaneus, how it's actually posteriorly dorsiflexed. Look at how the talus slides the way it's supposed to biomechanically, and then the calcaneal cuboid wedge and the drop navicular. Those are the consequences. So each one of my DVDs in the 4-DVD collection goes through the anatomy, the exams, the 3D animations of every single subluxation of the extremities that I treat, from upper, lower, carpal tunnel, TMJ, all of it, including the techniques, 3D graphics, and computer graphics, 3D animations. So that's something you may want to think about in ordering later in the day and when we talk about it. Now, everyone knows that I'm very much big into evidence-based science, but what we're going to do right now is go through a couple case studies just to move forward.
My name's Dennis. I'm a chiropractor in Michigan. I came to Dr. Malley's seminar for continuing education credits and to learn some new techniques about adjusting extremities. And I actually came with a personal problem that I didn't know could be helped. I've had foot drop for 7 years. It came on just out of the clear blue one morning, no known cause. I went to medical doctors. They did all their tests, including EMGs. They came up with no conclusions of what is wrong. And it consequently became worse, causing my gait to be very erratic and also knee pain. Dr. Malley, at one of the breaks, took a look at my feet, adjusted the calcaneus, and I got up immediately, had an incredible improvement in my gait. And by the end of the seminar, working on the rest of the bones of the feet, I'm walking as normally as I did before 7 years ago when I began having foot drop. It's just absolutely amazing to me. I would thoroughly encourage anybody to go to Dr. Malley's seminars. The information is incredible.
Thank you, Dennis.
It will help your patients a lot more with the material he provides for you. It's just.
Thank you very kindly. Now, how is it possible anybody in this listening audience who would take care of another chiropractor who has low back pain, sciatica, and foot drop, and then deals with this from a low back, and he's had EMGs, MRIs, he's had everything done, every possible technique. When I set the calcaneus, think about it. Foot drop, foot. It's not a novel concept, right? Foot drop. You have to understand how the peroneal nerve goes underneath the lateral malleolus. As you invert and sprain your ankle, it's quite common that the patient could end up with a common peroneal or, in fact, a deep peroneal nerve entrapment. Deep peroneal nerve is a branch off the sciatic nerve. So therefore, the afferent return from the valgus phenomena, from the foot all the way up the sciatic nerve, was manifesting as low back pain. Look, it's no different than a ballast on one of these lights above my head, these fluorescent lights. If a ballast starts to overheat, then the fuse box in a different part of the surgical center here trips a fuse. If you keep running as a chiropractor with 60 visits of moving that fuse, and then you got one person like you guys who's learned what a valgus phenomenon is, comes over and says, hey, the reason that switch keeps on tripping is because that ballast is bad, it's overheating. Let's take care of that. Doctors, it sounds easy. Look, how many of you know that there are 5 different entrapments for tarsal tunnel syndrome? This is right here. Anybody who's taken a nasty hop at a baseball game, a softball, and took a nasty hop could end up with paresthesia into the foot. Remember, the medial lateral plantar nerves are a branch off of the what? Posterior tibial nerve, which is a branch off of sciatic nerve. So if somebody's got burning in the foot and foot drop, it would behoove you to look at possibility of entrapment that occurs when the calcaneus displaces, and the majority of all of us have had not one, but numerous sprained ankles. And undetected, uncorrected sprained ankle is the same as walking around with an uncorrected, dislocated shoulder. Yes, it is the same. Because chronicity occurs and the tissue ends up going through a hysteretic change, a metamorphosis, and then you develop scar tissue with that misalignment called a dislocation. Subluxation is just a little bit less, right? So here are some things on Monday I want you to do is take a look at some of these landmarks and look at those. That's subtalar joint. Back here, the calcaneus to the talus, as well as the calcaneocuboid. Look at the offset that you see right there. On this end, you can see how the talotibial joint is compressed at a true 90 degrees. You can't say that's positioning error. That's a perfect x-ray. And then a line that should be drawn from the talus navicular cuneiform first metatarsal. I promise you, if you just start x-raying people, draw these lines, make these circles, and show patients, look, the foot's a 26-piece puzzle. Any misalignment in that puzzle will cause a change all the way up the kinetic chain. Them bones, them dry bones, remember? So here's a case of a gal. This is a fractured calcaneus, and she had surgery, 2 surgeries, and 6 screws.
I just want to say thanks because I haven't been able to move my feet for 1 year. I had 6 screws in my ankle, and I wasn't able to.
She wasn't able to move that foot. We're having a little technical difficulty here. I don't know what's going on with Zoom, but in any event, she wasn't able to move her foot or ankle for a year. 6 screws. And here's a concept of what it looks like. Okay. There's the fracture on the left side. Here you can see the cage in the middle and the number of screws in that particular foot. This is not hers. This is just an example. But here you can see about 10 screws into that calcaneus. Look, blessed are the flexible, for they bend before they break. Again, blessed are the flexible, for they bend before they break. So if a clavicle breaks, you got an AC joint and sternoclavicular joint that maintain misalignment that nobody ever fixed. Why? Because the fracture healed. I guess I'm okay now. I'll go back to activity. Now they end up with problems with their shoulder for a lifetime. So do you understand that these misalignments that we see, and you can see right on that middle illustration, that the subtalar joint is way posterior. This does not line up with the talar dome. Again, a posterior talus. Another condition. A benign perineural fibrosis. This is a scar tissue that envelops the area, very commonly from the medial plantar nerve between toes 3 and 4, and can be between toes 2 and 3. Morton's neuroma, another condition the medical doctor says, look, it's a sensory nerve. You don't need it. So they do surgery. The problem, ladies and gentlemen, my colleagues, is that's a sensory nerve, which is a branch off the sciatic nerve, which means you ever heard of phantom pain, stump pain? So what do you think happens if the sensory nerve is now stopped here as opposed to at the end? The patient feels the toe is still there. They still have pain, but the doctor is treating them for low back pain, not aware of the importance of the lower extremity history taking. Look, Mrs. Jones, did you ever have any surgery to your foot? Oh, yeah, I had a bunion. Oh, I had a Morton's neuroma. Oh, okay, well, that's the reason why you have chronic low back pain. That's a valgus phenomenon, ladies and gentlemen. You have to make the patient aware. And the reason why that's important, you can't fix the fact that the nerve has been cut. What you can fix is what caused it, which is a metatarsal phalangeal shift, such as this illustration. Take a look at number 2-3 and number 3-4. The joint between 2 and 3 on this particular patient was a Morton's interdigital neuritis. And between 3 and 4, it actually looked a little bit better than the one between 2 and 3. This is one of the patients with a Morton's neuroma between toes 2 and 3. Can you restore alignment of the metatarsals? Yes, 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 doctors. Join the Extremity Experts Academy. Learn my techniques. Learn this content because you'll make a difference and you're going to stop people from unnecessary drugs and surgery. Bottom line, increase profitability for you based on outcomes. Outcome will always generate income. So take a look, gather your interest right now. Here's the big toe. And right here is the Morton's interdigital neuritis. That's an actual neuroma. And coloring it red there, you can actually see a little bit better. Here you can see the neuroma. And yes, those can be quite uncomfortable, obviously. Okay, so now let's go ahead. And this is a New York City best-selling author. This is an absolute touching case. Let's see if this will work here for you. If not, you can always go to drmitchmalley.com.
Hi, my name is Mitch, and I am at the California Chiropractic Association convention, and I just met Dr. Malley. I heard about his treatment on plantar fasciitis, and I have been suffering from plantar fasciitis since I was 13 years old. And since
let's go ahead and just play it again.
I had my first baby, he's almost 7 years old. I have been suffering from numbness in my 3 toes and on my left foot, and also the plantar fasciitis that bothers me every day. And he adjusts both of my feet today, and I'm amazed to say that I can feel my toes again. And I haven't even put my shoes yet because I want to feel the temperature of the floor because I couldn't even feel the temperature roll in both of my feet. And I just cannot thank him enough for what he has done today.
Her husband's a chiropractor, famous individual, has written a book, and fantastic. Again, why do people have to suffer these conditions over and over and over again for all these years? He's a chiropractor. He brought her to me. I went ahead and adjusted her one time. I was just in touch with him the other day. She has not had a single reoccurrence, and that was over a year ago. So everything we talk about is evidence-based. Now, let me ask you a question. If we have a spring between my 2 fingers and we stretch that spring, does it make sense to stretch it further? No. That's what's happening with plantar fasciitis. The Strasbourg boot, Strasbourg sock, and all of you are telling person to stretch, bring the toes toward the nose and stretch, stretch, stretch. The problem is when you have a normal arch and it collapses, it already overstretches the fascia to begin with. It's contraindicated, doctors. Why would you tell somebody to stretch and then turn around and put an arch support in the foot and tape the arch up? What is it? Are you going to stretch it, or are you going to put an orthotic in to build an arch? The answer is quite obvious. Stop stretching it. It's already been overstretched. We don't do any of that. What we do is we work the heel toward the ball of the foot together to lift it. And my soft tissue department is to prepare before I repair. When people think soft tissue is the answer, you are 100% wrong. Is the problem the rust or the dent in the fender? So look, soft tissue is fine. I have a great soft tissue department, but they know their role. Their role is to prepare, and the way I teach them in the Extremity Experts Academy and the soft tissue work is to prepare for us to repair. I know I might be stepping on some people's toes, but that's okay. I know how to fix those as well. Everything I teach you is evidence-based science. Let's continue right now. Journal Manipulative Therapy, 2018 article, and if you look at the bottom, notice what it says. It said stretching. So I cross it off and I say, look, manual therapy does help function, but eliminate the stretching. Next, how about cutting? Look at the very top paragraph where it talks about gastrocnemius recession. How about if we just cut the gastroc to make a difference and then put the patient on stretching? No, again, you're mistaking the problem. Look, why are you going to cut the ligaments on the shoulder that's dislocated? Why are you going to take that dislocated shoulder and stretch it? Doctors, it's already overstretched. So that's why I get a little excited about this. Stretching, stretching, stretching. It's not cut out for what it should be, right? Okay, next, manual therapy for plantar of heel pain. What do you guys think? Should we have people have soft tissue mobilization? That's what physical therapists do. They come to you as a chiropractor because they want to get adjusted. And thank you, Christy, for what you said and alluded to. Your husband got in a line and everybody's in line to get adjusted. I think it was one of the Parker seminars around 2011. And my wife, you have to sign a little release. Well, in order for me to see I adjusted in 4.5 hours, 278 doctors. I about dropped dead. A lot of people don't do that in a week, let alone a month. And we did that in 4.5 hours. One body part. Yes, it's not bragging people. It's comfort level like you are to a student starting. You can adjust and they go, wow, how did you do that so quick? Well, for me, this is my level of expertise I want to share and bring to you through Extremity Experts Academy. It is a one-of-a-kind opportunity, and now is the time. The luxury is lemonade out of lemons. Take advantage of the learning of this content and start on your own time on my online program. It's easy. It's a lot of content too. All right. It's taken thousands of hours, and I never had that time because on an average, I'm doing 50 to 60 events worldwide plus 8 internationals this year. And that's changed a little bit, unfortunately, until somebody obviates travel restrictions, lifting those so we can travel again. Plantar fasciitis, platelets. You hear everybody talking about stem cell and platelets. That's great, but put the joint back in place. Look, a medical doctor tells you with a sprained ankle to get off it, strap it, maybe ice it, get off of it, right? So let's take a wheel out of alignment and park it in a garage. In 4 weeks, you still have a wheel out of alignment. So now let's go take it to the physical therapist, and the orthopedist says, go do rehab. So now you take that wheel out of alignment and go race it on a racetrack. This is happening every day. Chiropractors, we need to make a difference. Look, there's enough infantry in our profession. We need more snipers, need more people who are excited, motivated, inspired to make a difference. And this is why we're doing this. It's all evidence-based, everything I teach and have been teaching. Neural therapy. How about injecting local steroids? How about cutting more tissue, scar tissue, etc.? No, not necessary. Okay? Heel cups, orthotics, things like that can make a difference. Number 2, how do knee mechanics affect low back problems? Postural distortions happen from the bottom up, right? So foot mechanics affects knee, hip, pelvis, and spine. Again, look, if I got cracks in the walls of my home and the plaster is cracking and the floors and the windows and doors aren't working the way they should, floors are squeaking, the problem's a shift, obviously, in the what? That's correct, foundation. Epidemiologically, the knee from pivotal injuries, approximately 70% of injuries are from pivot, which means the foot is planted. I take care of a very, very well-known PGA player who we'll just say the golfer's golf coach has been working for over 15 years to get rid of anterior sway in the swing. It turned out the individual's anterior sway was because of faulty foot mechanics. It's the same reason why one of the most well-known male golfers who has had repeated knee, hip, pelvis, and low back problems is because nobody's corrected what? Faulty foot mechanics, and nobody's looked for his leg length inequality, which we're going to get to in just a moment. Guys doing okay? The steam is coming off my lips. Let's continue. If you want to take care of low backs, let's take a look at Clement et al. In the article, it said that nearly 96% of sports-oriented environment type cases, 96% of them are outside of the spine. They're the knee, right? We've talked about the knee, the foot, the leg, the hip. These are outside of the spine that are contributing to low back problems. So yes, you should get excited about this and motivated and inspired, because remember, when a tibia moves one way, the femur has to move the other. That's how the actual biomechanics works of the knee to ensure proper mechanism. It's called a screw home mechanism of the knee. That's when you have a problem with a foot that causes rotation of the tibia, the femur moves opposite. It's a ginglymus joint, largest, most complex joint in the body. Remember, the medial femoral condyle is 1.7 centimeters larger than the lateral, making the medial compartment stronger, yet it still has the most common injuries noted in the knee. So what does the anatomy look like? That's a good review. Let's get into the biomechanics. Torsion. Tibial torsion is normal biomechanics. Tibial torsion syndrome is not. Carpal tunnel is not a problem. Carpal tunnel syndrome is. You look at the grimace of pain. This is what ended my football career right here, is a kickoff return, and I blew out my left knee, and I planted my foot, again, a high pivot move. But the femur torque Deformity is noted relative to patellofemoral discomfort and instability that results in chondromalacia. It's called the screw-home mechanism of the knee. Now, my research has led to the patellotibial tubercle test. It's a test where you can identify that the tibial tubercle in its central location is crucial. Why? Because you can end up having a patient like this where the lower images on MRI show you these coronal images. I put arrows on it to help you identify. Look above at the top picture, look at the lower two pictures. You can see that the femur and the tibia are not aligned. Well, the radiologist reported these are normal. Why were they normal? No pathology, no ligamentous tearing. They just didn't understand the biomechanics of the knee. And the radiologist that I treat that flies here from Florida to get treated, this individual says, no, we don't know anything about the biomechanics of the joints. That's not what we're taught. That knee right there is normal. I said, really? Let me show you the arrows. Let me show you normal. He said, my God, all these years I've been reporting wrong. And the same thing happens in the shoulder when people are reporting rotator cuff impingement, which is 55.5% of all shoulder conditions are rotator cuff involvement. Impingement is the most common. And the acromion gets pulled downward by the action of the pec minor, which makes the radiologist look at this and say the subacromial space is less than what it should be. It's what I call an optical delusion. It's an optical delusion. And the radiologist says, my God, I've been reporting rotator cuff impingement because subacromial space is less. And you're telling me it's less because the scapula is protracted and anti-tilted? Yes. That's not just me. It's Seha, Tulos, Mosley, Brewers, and Kibler's studies support what I've been teaching for 40 years. They just don't know how to fix it. The American Physical Therapy Association works on the pec minor being short. The reason it's short is because of the arthrokinematics of what I teach in the Extremity Experts Academy. I hope I've piqued your interest. I hope I'm making this exciting for you because I hope you feel my love and passion, doctors. I'm like this all the day. My wife calls me Energizer Bunny on steroids. Okay, now let's take a look at this case study. I just picked a couple of them real quick. Notice the difference here on the left side of the retropatellar cartilage. And on this right one right here, the name of that condition when the cartilage breaks down and grinds and bothers people more going down the hill and down the stairs than they do up the stairs, and we talk about that and why. That condition is called chondromalacia patella. Let's look at an axial view of the same condition and look at the difference, and this is called a merchant view if it were an x-ray, or an axial view on an MRI. This case is chondromalacia patella. You see the tracking of the patella is moving, and it's actually causing more what's called lateralization of the patella. Now I'm going to put you to work for a moment. I'm going to call maybe about 10 seconds. I want you to look at each of these quadrants. Top left, what do you see different there? Well, this is a patient we're going to diagnose in a little bit with anesomelia. Now, the top right, that's an old Osgood Schlatter's. The lower left, tibial torsion syndrome, the rotation of the tibia. On the bottom right is femoral anteversion. If you look at the patellas, you'll see something right there is a patella alta, elevated patella. So you see observation as one of those very important things to look at. Now, this one really bothers me. This is something I personally experienced. Kickoff return and planted my cleat, made a high-speed pivot, and blew out my knee, tearing everything. The literature supports the terminology called external tibial torsion, an under-recognized cause of recurrent patellar dislocation. It's a violent rotation of the tibia externally and a counter-rotation of the femur antero-inferiorly. Well, what's that going to do at the knee? Tell me what it's doing at the hip. What's happening at the femoral acetabular joint is similar to what's happening at the distal end. For those of you who grew up in the hood like I did in Detroit, man, I'll tell you what, you see a lot of people going down with injuries like this. And the torque that occurs is called tibial torsion syndrome, where the tibia is no longer aligned, and that's because of faulty foot mechanics. And that can occur from a lateral force, a medial force, or an impact type of biomechanic. If you remember an impact biomechanic that occurs to the top of the shoulder, that's right if you said a Hill-Sachs deformity, because that's an impact fracture that occurs from a dislocation. In this case, an impact like this will cause a PCL tear, and that can happen in a car accident, a slip, a fall, or what have you. Even the bursa mechanics, doctors, colleagues, the flexion to extension of what occurs in the bursa is the dispersion of the fluids. So if the tibia actually That's a reminder. If the tibia glides posteriorly, then the fluid will move anteriorly. Let's continue. This guy had right 4 knee replacements, and he ended up with an 18 millimeter leg length discrepancy. Look at the difference immediately. You can't adjust this. He's had umpteen adjustments. You will not make that low back pain and sciatica go away because his leg length was different. 18 millimeters correcting his shoes, modified and corrected his problem. Don't do efficiently what you need not have to do. You may have to do something like an outsole, and you may have to send that patient to an orthotist, podiatrist, or you have to send them to a shoe cobbler. How does hip mechanics, number 3, affect or contribute? Very simply stated. We talked about in the middle illustration how foot rotates knee, and now how knee rotates hip. So the hip anatomy is very simple. You take a look at this as biomechanics. Remember that the muscles attach to the what? Femur. So if the femur is anteverted, which means it's going anterior away from you, it's going into your computer screen. Doctors, if it goes into your computer screen and then toward the groin, that's called femoral anteversion. It's stretching the piriformis. The piriformis stretch reflex causes it to contract. The last thing you want to do is stretch that muscle. Correct the reason why. Muscle is stupid. It is secondary to what a neurogenic musculoskeletal is going to do. Neuromusculoskeletal. Correct the neurological dysfunction and work with the muscle as well. Understanding this, then you know that the piriformis muscle, the superior and inferior gemellus, as well as the quadratus femoris, you've got lots of things. What's more exciting? How about this one? A lot of people get misdiagnosed with a condition, an entrapment neuropathy on the front, otherwise known as Bernhardt-Roth syndrome. Lateral femoral cutaneous nerve, as well as in the inguinal area, you have what's called the anterior femoral cutaneous nerve. These nerves can be compressed by a tight belt, or during delivery process, if the legs are up in stirrups and bearing down, they can crush the nerve. Anything along that lines, like a construction worker that wears a tight belt, or a cop. I see a lot of cops and firefighters, and man, they do have this problem as well. Number 4, the pelvic biomechanics. What happens in the pelvis is very, very simple. Very simple. Let's skip that and go right to the core center of gravity. What happens here is that the faulty foot mechanics is going to cause the tibia to go posterior, the femur to move anterior, the ilium to rock posterior. Remember the femoral acetabular joint. We're going to show you in just a moment. But when the pelvis rocks posterior and the sacrum tilts, you're going to get an alteration in the lumbar spine, dishing in the middle upper spine, and a reversing of the cervical spine. That changes the COG, your core center of gravity. And when that happens, colleagues, that's where the spine ends up with biomechanical aberration and changes. So I look at the scoliosis as a result. While many people are trying to fix scoli, I'm trying to fix what caused it. A little different angle, isn't it? So let's look at the hip biomechanics. Notice this bottom left picture in front of you. It's kind of in the center bottom. Notice how the arrow is pointing what happens. The femur, when it anteverts, is going to create femoral acetabular pressure, and the labrum as well as the hip joint itself, and I just broke mine August 7th, had surgery August 8th with 3 screws put in, but that's going to cause sacroiliac problem. And as you end up with a sacroiliac problem, you're going to end up having sacral tilt, and the condition just continues to change. Look here. The femur, if it moves anterior medially, what's it going to do to the iliacus and psoas? Well, if the acetabulum during gait moves forward toward you, the ilium is going to move posterior and inferior. As the femur moves medial, then the ilium will be PIEX. What is that going to do to the lumbar spine? It's going to pull on it. Of course, it's going to show a tight psoas. Of course, you're going to see a tight piriformis muscle because the trochanter is moved anteroinferiorly. So that'll pull on the sacrum when the piriformis tightens. The sacral apex is going to turn to your right in an acute. Sacroiliac is going to become a chronic PIEX. And then you're going to end up with a scoliotic change, an L5S1. You're going to see an L5 wedge formed on the acute ipsilateral side. If that isn't enough, let's go back to 1895 was chiropractic, right? How about 1840 to 1860? Published in 1860, 35 years before chiropractic, in the Royal Surgeons of England, printed by a neurosurgeon, Dr. John Hilton, MD, who found the most low back problems, lumbago, sciatica, degenerative hip and knee problems, and other sequelae from the low back down were the result of one limb being shorter than its contralateral fellow. He found that he would take a stack of brochures, stick them underneath a short limb until there was a want for symmetry. But look, that's not really accurate, nor is what one of my student interns just learned, how to put a tape measure on the belly button and measure to the malleolus. Also not accurate, nor is femur heads or the height of the iliac crest. In the Extremity Experts Academy, we also teach you the condition called anisomelia and how to evaluate that with leg length x-ray, a proper procedure. And it is billable for the diagnosis. The proper coding Q72.811.812. Now, if structure equals function, we're wrapping up. If structure equals function, then function is a result of structure. So the difference is, why aren't we looking for these? Here's an example of 27 millimeters and an instant change by just retaking an x-ray within seconds after the diagnosis. This person had 6 months of problems. 6 months of problems after they had a knee replacement. Keeps going back to the orthopedic surgeon. This is an old hip fracture. Disregard what you're seeing there with the arthrodesis. But the knee was replaced. And for 6 months, the patient's complaining to the orthopedic surgeon, I got low back pain, sciatica, sacroiliac, my low back is killing me, doctor, what should I do? Sent the patient for 6 months. They go to physical therapy, return, injection. And he says, you know what? I'm going to send you to Dr. Malley. He does something very unique. Well, take a look at the iliac crest. That number is not the same as the number of the femur heads. So that's inaccurate, doctors. What you're seeing here is a lead ruler, part of the orthorencanogram, the study that we used from 1924 from Hickey. We've mastered that. I've done over 7,000. If it's the largest or smallest, it doesn't matter. It's a lot of people. From 1999, when I brought this procedure into the chiropractic profession, over 7,000 studies. You were told, so was I, that there are more functional short legs than there are structural. That is a big fallacy. The problem is structure equals functional. So if they have a functional short leg, look at the structure and you'll find what I did. 90 to 92% of your patients and mine and every listener around the world, if they have their own joint, 90 to 92% have one leg shorter than the other. That's called anisomelia. Look at the difference. Again, look at the difference in the pelvis and the spine after just seconds. You could adjust that patient on the left as they've been adjusted for 6 months to no avail. Or you could learn my procedures and correct this condition on all your patients. Let's go ahead and listen quickly.
Ron, you presented with what's going on in your feet? Burning. And how long have you had this neuropathy?
Probably 15 years.
Okay. Now today I just did a first manipulation to your feet.
Yes.
What did they feel like when you walked?
Entirely different.
In what way?
I think I'm balanced.
Okay. Let's watch you walk now.
I have to learn to walk again.
All right, turn around.
If you didn't hear me, I has to learn to walk again.
What's that feel like?
It's so different.
So he says he has to learn to walk again. We won't have time to watch each and every one of these, but this is 15 years of neuropathy imbalance, treated, correcting his imbalance, and it was life-changing for him. Another patient, 50 treatments to chiropractors. Why did they fail? Oh, the chiropractors didn't do something right? No. I'm never going to accuse anybody. What I am going to do is educate everybody. Look, sciatica, low back pain, this is what the recalcitrant low back is. It's chronic. It's refractory. You've tried everything. Still left heel numbness. We have to understand these nerves, Baxter's neuropathy. If you look it up, you'll see it's a branch off the sciatic nerve. So if somebody's got a problem with the foot, it doesn't mean, with numbness on the leg, doesn't mean going into the foot that it's a low back or disc problem. It could be the result. So to save time, go to my YouTube channel, drmitchmalley.com, select at the very top videos, watch, look, learn, listen, and then join the Extremity Experts Academy, ladies and gentlemen. That's where you're going to learn cases like this woman who had a stroke, couldn't extend her legs. She had 2 strokes. She couldn't separate her knees, and she had 1 foot over the top of the other foot, unable to, until I corrected a calcaneus on each foot. She was able to extend both legs out, the knees separated, and the feet uncrossed. She was amazed. Even her shoulder and neck improved sitting in a chair, and all I did was correct her calcaneus. Is it amazing? Yeah, but why should it be amazing? It should be normal. Power that made the body heals the body, right? Dr. Greg Logan out of Sarasota, Florida, low back pain, flew up here. We did a leg length measurement, found and corrected his problem as well. Why do people have to suffer? Even our own colleagues? I'll tell you why. If you want to earn it, you need to learn it. Learn it to earn it, doctors. Here's an ex-pro basketball player with 15 years, a chiropractor, 15 years of sciatica neuropathy. He came to one of my courses in Oregon, he ended up ordering the leg length protocol and started doing it on everybody, almost every single patient. He's now clearing people he's been treating for 5, 10, 20, 30 years. In practice, he's clearing them immediately. Why? Because that short leg that you adjust on the table and you recheck with this Deerfield leg check doesn't mean anything, because when the patient stands up, they're standing with one leg shorter than the other. Remember the statistic I gave you of 90 to 92% of the people have one leg shorter than the other? Guess what? When you x-ray a patient who's had a total knee or total hip replacement or bilateral, that number goes to 99.9. Here's a young lady who was a great athlete, another one that flew up here from Florida. All these people diagnosed with anosoglia. So look, whether you're a novice or you're an expert, we can all learn. Doctor in front of my name means how much I don't know. But I hold all kinds of different workshops. We train people. I have a 2-year fellowship program. We teach you how to do these different clinics and presentations and how to generate volumes of cases. Look, when you x-ray a patient, there's also a code that you can use for the RAD report, just a -26 modifier. How many use for muscle tests? 95831 that you can charge on a different day for muscle tests. Look, you want value? You want it to pay for itself? Do what we're telling you to do here. Corporate wellness and other types of things that we do. What's newsworthy? Whether it's a celebrity or a specialty case, people are looking for stories that have good endings these days, right? Aren't we? So what does extremities really do for you? If you have a patient with low back problem, rather than just x-raying 2 views of the low back, for example, we do the 4 views of a low back. We do the leg length x-ray on a separate day. Can't do it same day. And you can't use that for an AP pelvis. You're going to get in trouble for fraudulent billing. So there's so many things that you're leaving on the table, doctors, that we will show you how you could take your existing patients, even if you didn't have a single new one, how you can actually double or triple your practice very simply by doing some of the things that we say. Am I opening my mouth and putting my foot in it? Well, I guess maybe I am. But if you try what we say, maybe your practice too will increase a level of mastery. I know my patients deserve it. So do yours. Practice the 7 Ds. Have dedication to what you're doing, a desire, be determined, show a direction. Have that desire, and you too, with self-determination, self-drive, you too can succeed. My philosophy is very, very simple. It's God. I give everything to the good Lord. I'm very faith-based, but I also have the law of perseverance, which says, in the never-ending battle between the rock and the stream always prevails, not by strength, but by perseverance. Also, God has a purpose for your pain, doctors, a reason for your struggles, and a reward for your faithfulness. Don't give up. Look, Rocky said it years ago. Life's not about how hard a hit you can give. It's about how hard a hit you can take and still keep moving forward. So continue to practice, become perfect, become the best you can be, like a sniper. I train with a SWAT team sniper because I want to be number one. I want to be better, so I have to find my weaknesses and strengthen them. Because if I provide the quality, I'll always have the quantity. Outcome generates income. Look, I'm not lying about this. These people are waiting for it. I told the jokes suck, right? But these are also waiting in the midst are the genetic people, the hereditary, the people waiting to see you because you make a difference. Here is a good friend. Let's listen up to a final closing comment.
Dr. Pat Mancini, and listen, I wanted to take a moment to talk to you about Dr. Mitch. I've known Mitch for probably over 20 years now. And of course, I've always said to everyone in the audiences that I participated with that Mitch is probably one of the greatest gurus in chiropractic, especially when it comes to teaching you extremities, to also showing you how to implement the treatment of extremities into your practice.
That's what we do. So let's just move forward and just tell you, and wrapping it up, you guys can look at all kinds of things. But here's what I want you to do. Considering right now, a lot of people are going, woe is me. I'm saying, wow is me. What an opportunity for you to reach for the stars. A great time to buckle down. Look at your caseload. Look at how many patients may, in fact, have a Valix phenomena that's been undetected, uncorrected, and you can now build that practice of your dream. So it's time to make the decision for precision. Increase your level of mastery. Watch the video. Doctors, your level of mastery is up to you. Malley Method of Clinical Excellence is part of our program, the Extremity Experts Academy, including live workshops. All you have to do is just join the Extremity Experts Academy. Just go and open up an account at drmalley.com. Start your journey. Enjoy the adventure. You'll learn exam, radiology, and then you can qualify to come to the live workshops. You can also right now begin immediately by ordering the DVD collection of all my extremity work. That's the lower extremity, foot, knee, hip, pelvis, spine. Then it goes to shoulder, elbow, wrist, hand, carpal tunnel, the 17 entrapment neuropathies, and the TMJ. All with 3D animation, computer graphics, aligns the angles, the techniques, abstracts, and a whole lot more. Doctors, this has been an absolute honor, a privilege, and thank you so much to ChiroHealthUSA. Thank you, Christy, for the opportunity to bring some of my knowledge and an overview in a very rapid. I hope you guys can keep up and have fun. Just remember my tagline, make the decision for precision, and you have to learn it if you want to earn it. I turn it to you, Christy.
Thank you so much, Dr. Malley, and thank you to all of you who took an hour out of your day to spend with us today. If you have any questions for Dr. Malley, feel free to put those in the chat box now. If you are like me and think of all of your questions later in the day or the next day, or you're watching this recording, just feel free to email me at christy@ChiroHealthUSA.com, and I'll be happy to get those over to Dr. Malley. We'll get those questions answered and sent back to you. Just know that every question that you submit through the chat box, even if it is after today's webinar has closed and you are watching the recording, is emailed directly to us so that we can get those questions answered. Just want to remind you that we have another webinar for this week as we are all trying to navigate the world of life with COVID-19. We'll be addressing HHS payments, employment law, and reopening your practice with Dr. Scott Munsterman and Steve Conway on Thursday at noon Central, 1 o'clock Eastern Time. If you have not registered for that webinar just yet, go to our website at ChiroHealthUSA.com/webinars, and you can go ahead and register for that. Also, just wanted to let you know that this webinar is being recorded and you do not have to request that. We are going to send that automatically to you in about an hour, hour and a half, so that you can go back and rewatch this. I know several of you were like, wow, Dr. Malley talks super fast. And yes, he does. But that's because he gives y'all like 3 hours worth of information and crams it into 1 hour and 7 seconds. And that was legit because I was watching the timer. So, yes, but he is that fast talking, even whether he's talking for an hour, 4 hours, or 12. So go back, watch it again. You can pause it, make notes, watch it some more, pause it, make notes. Y'all do know that there is no rewind or fast forward function in the software. So I do know that when you are emailing me your suggestions, I have already made those suggestions to the software company. So hopefully that'll be part of our next update. So I don't see any questions coming in. Dr. Niederman wanted to say, best wishes from Casey and myself to you and your wife. Please have a great year. I hope to see you soon. Nice ending video too.
Thank you. God bless to all of you. Stay healthy. I look forward to seeing you in the very near future. Ask your state associations to bring me in. We can do Zoom, and we can do more of these webinars anytime you'd like.
Thank you so much, Dr. Malley. And everybody, don't forget to wait till the end of the presentation and provide your feedback. If you'd like to provide additional feedback that is not available through the software, feel free to email me. You can also make suggestions for future speakers and topics that you are looking forward to seeing on the webinar series. Thank you so much again for joining us today, and I will see you Thursday. Bye, everybody.
Bye now. Thank you, Christy.